the home and the lovely. Our finally attracted is checkmate 743, first-line Nivolumab plus the EP versus the chemotherapy in unresectable malignant pleural mesothelioma. This is presented by the Professor Paul de Baas, Professor of Oncology, University of Amsterdam, Netherlands. The discussion will be the Dr. Dim de Fresnel. He's the chair of the Thoracic Medicine Oncology, Cancer Research UK Center, Leicester, England. Yeah, please.
It's a great pleasure to present you on behalf of the co-authors the Checkmate 743 study. This is the first-line Nivolumab plus Ipilimumab versus chemotherapy in patients with unresectable malignant pleural mesothelioma. These are my disclosures. We have been trying to improve the overall survival of patients with mesothelioma now for many decades. We have a platinum pemetrexed as a standard of care, but the 5-year survival rate is still below 10%. There are two subtypes of this tumor, the epithelioid histology, which we know performs better than in the non-epithelioid histology. Nivolumab and Ipilimumab are checkpoint inhibitors of the immune system. They have a complementary mechanism of action. Nivo and Ipi has shown to give durable survival benefits in a variety of malignancies. For second-line treatment of patients with mesothelioma, ICIs have been tested, but they did not show any significant benefits. However, there were 2 reports of a clinical activity of Nivo and Ipi in the second line for patients with mesothelioma. Therefore, the Checkmate 743 study, a randomized phase 3 study, was started. Patients with unresectable pleural mesothelioma who had not received a prior systemic therapy and were in good performance were stratified on histology and gender. 303 patients received Nivolumab, 3 milligrams per kilogram every 2 weeks, plus Ipilimumab, 1 milligram per kilogram every 6 weeks for up to 2 years. 302 patients were randomized to receive cisplatin or carboplatin with pemetrexed, given every 3 weeks for 6 cycles. The primary endpoint was overall survival, and there were secondary endpoints defined. There was a database lock on April this year. If we look at the statistical considerations, we plan to detect a hazard ratio of 0.72 with a power of 90% and 5% type 1 error. Therefore, 600 patients had to be randomized. There was a pre-specified interim analysis when 85% of the events had happened, and this was done by an independent data monitoring committee. At the time of analysis, 89% of the total death had occurred, so we're talking about a mature study. There was a minimum follow-up of 22.1 months and a median follow-up of 29 months. The Data Monitoring Committee confirmed that the primary endpoint of improved overall survival for Nivo and Ipi versus chemotherapy was met. The baseline characteristics are shown here, and they were well balanced between the 2 arms. Coming to the primary endpoint of overall survival, the Kaplan-Meier curve shows that the median overall survival of Nivolumab plus Ipilimumab was 18.1 months. For chemotherapy, this was 14.1 months, translating into a hazard ratio of 0.74. The p-value was 0.002. At the 2-year mark, 41% of the patients in the experimental arm were alive versus 27% for the chemotherapy. Patients could have a subsequent therapy, and this occurred in 44% of the patients in the experimental arm versus 41% in the patients receiving chemotherapy. And 20% of these had an immune checkpoint inhibitor as subsequent therapy. Now, looking at the subgroup analysis in this forest plot, you can identify that the majority of the subgroups had benefit from the experimental arm, and we could not identify any subgroup that was harmed by the immune checkpoint inhibitors. Going more into detail for the histology, there are a few interesting observations to be made. First of all, the experimental arm performed better than chemotherapy in both subgroups. Nivo and Ipi had a median overall survival of 18.7 months in the epithelioid one, and in the non-epithelioid one, it was almost the same with 18.1 months. Comparing the immune checkpoint inhibitors with chemotherapy, the hazard ratio in the epithelioid arm was 0.86, with the confidence interval crossing the unity, but in the non-epithelioid arm, the hazard ratio was 0.46. The median overall survival here was 8.8 months for the chemotherapy, and this is in line what we know from historic controls. Focusing on PD-L1, which is always in debate what the value is of PD-L1 in mesothelioma, we decided to look at the absence or the presence of PD-L1 in the tumor. If we look at the absence of PD-L1, the performance of the experimental arm and the chemotherapy arm is the same. But in the case there is any expression of PD-L1, the experimental arm performs better with 18.0 months versus 13.3 months for chemotherapy, a hazard ratio of 0.68. Looking at the progression-free survival, and we know from experience that due to the way the tumor growth, this might be difficult to interpret in some cases, we see that the chemotherapy arm in the first 6 months performs a little bit better, but then the curves cross and the advantage is for the experimental arm. For the analysis, the modified RECIST criteria were used. In both arms, there were almost the same number of responses. The chemotherapy arm, only partial responses were observed, while in the experimental arm, 2% of the patients had a complete response. Now, if you had a complete response, there was a great advantage for the experimental arm with at 2 years, 32% had still no signs of progression versus 8% for the chemotherapy arm. Looking at the safety, 80% of the patients experienced in both arms any kind of toxicity. The adverse events leading to a change in the treatment was 23% in the Nivo and Ipi arm versus 60% in the chemotherapy arm. But one can appreciate that the immunotherapy was given for a period of up to 2 years. Serious adverse events were occurring more often in the experimental arm, 21%, versus 8% in the chemotherapy arm. There were 3 patients who died in the experimental arm related to the drugs, while there was only 1 in the chemotherapy arm. If we focus more on the treatment-related immune side effects, it is what we expect from other studies. The majority was skin, gastrointestinal, and endocrine, but for grade 3 and 4, we saw a bit more hepatic and gastrointestinal toxicity. So coming to my conclusions, the CheckMate 743 study met its primary endpoint of statistically improving overall survival for the experimental arm versus chemotherapy in a pre-specified interim analysis. Hazard ratio 0.74, 2-year survival, 41% versus 27%. The survival benefit of the Nivo and Ipi versus chemo was observed regardless the histology, and the chemotherapy performed better in the epithelioid one as expected. PD-L1 data are descriptive, and we cannot preclude any conclusions from this. There were no new safety profiles that were consistent with what we have seen at that dose and schedule. So this is the first positive randomized trial of dual immunotherapy in the first-line treatment of patients with mesothelioma. Therefore, Nivo and Ipi should be considered as a new standard of care. I would like to thank the patients and family who made this trial possible, and the study was supported by Bristol Myers Squibb. All authors contributed to and approved this presentation, and they are presented in this slide. Thank you for your attention.
My pleasure to discuss the results of the Checkmate 743 trial. The title of my talk raises the question of whether or not this study represents the first, perhaps bona fide, stratified therapy for mesothelioma. These are my disclosures. I'll start first by briefly discussing the results of 743, top-line results in context. There have been 4 randomized phase 3 trials in the first-line setting over a period of 17 years. The first of these was, of course, cisplatin pemetrexed versus cisplatin, which was positive with a hazard ratio of 0.77. Subsequent studies, including a study that showed for the first time in 2016 superiority of an added drug, bevacizumab with pemetrexed versus chemotherapy, standard chemotherapy, was followed by a bold study of Ipilimumab, Nivolumab versus chemotherapy. Hazard ratio is numerically lower than any of these prior studies. And the question, of course, is how did we get to this combination and randomized trial? So this is a summary of the immune checkpoint inhibitor studies in mesothelioma over the last approximately half decade. We can see in orange the studies which are related to monotherapy and those studies of combinations in green here. Of note, the Checkmate 743 study is the first study to read out, certainly phase 3 in the first-line setting. Prior studies at phase 3 level, the CTLA-4 Tremelimumab versus placebo study was negative, as was the anti-PD-1 pembrolizumab versus chemotherapy study that was reported last year. Ipilimumab and Nivolumab have been evaluated in both the Initiate and the MAX2 trials. We can compare data with Checkmate 743 here. What's very clear is that the response rate was slightly higher and the disease control rate was slightly longer and slightly higher as well. And this is perhaps not surprising given the fact that these 2 previous trials, Initiate, MAX2, were in the relapse setting. The PFS, the 12-month survival and the overall survival were also longer than previously reported, but not a million miles away, suggesting that these drugs, this immunotherapy, does have significant activity in the relapse setting. Well, this is the pivotal data for me in this study. On the left, the non-epithelioid mesothelioma subgroup showing a distinct difference between Ipilimumab, Nivolumab, and chemotherapy, with a poorly performing chemotherapy on, you can see 8.8 months here. In contrast with epithelioid mesothelioma, we can see these survival curves approximated with what appears to be a control arm that is performing as it would be expected, as comparing the meso epithelioid arm in this phase 3 compared with the Checkmate 743 control arm. Of note, if we begin to look at the Ipilimumab Nivolumab across histological subtypes, we see there is essentially no difference. 0.93 hazard ratio, not significantly different. But when we look at the chemotherapy across these 2 histological subtypes, what we can clearly see is a significant difference, a large difference, more than approximately a doubling of overall survival for epithelioid, with a hazard ratio significant at 0.47 for this comparison. In the Ipilimumab survival curve, we can see here going out to 36 months, a plateau of about 30%. And this is censored, suggesting that, as we've seen with other trials of immunotherapy, there is a degree of durability which is seen way beyond what we've seen previously with chemotherapy. And this indeed may have been driven by maintenance nivolumab. We look at safety, risk-benefit, no real differences in all cause treatment-related adverse effects. We do see a doubling here of serious treatment-related adverse events, grade 3, 4, approximately 15 over 6, or 5% versus 2%. So the non-epithelioid mesothelioma, I think the balance is very much in favor of ipilimumab, nivolumab. Based on the efficacy and safety, I would say things are really in balance for epithelioid, possibly tilting slightly towards chemotherapy based on the safety. So what's driving the signal in the non-epithelioid histology? We can see here that the prognosis for sarcomatoid biphasic is much worse than for epithelioid. And in looking at the expression of vimentin and Z1, these are proteins associated with EMT, we can see that expression in the non-epithelioid, but not in the epithelioid subtype. And this is reflected also in the transcriptome, where if we go from epithelioid on the left to sarcomatoid on the right, EMT signature is enriched. Now, what does this mean? Well, as you have enrichment of EMT, what you see is increased drug resistance, increased invasiveness, something we know well with sarcomatoid mesotheliomas in particular. And this drug resistance phenotype may account for the drug resistance that we see in the CheckMate 743 with chemotherapy. This does not appear, though, to impact in any way the efficacy of the immunotherapy. What about PD-L1? Well, PD-L1 has been equivocal, really, as a biomarker in mesothelioma. Is it predictive? Is it prognostic? Here we see it as being predictive in the INITIATE trial, 22C3, significant p-value, but not in the MAPS2 study. In the CheckMate 743, however, we see an improvement in overall survival for those patients with PD-L1 expression. The question is it positively predictive, as in lung cancer, or not? Well, the answer is it's probably negatively prognostic. We can see patients doing worse with chemotherapy here, 13.3 months versus 16.5, and only marginally better with PD-L1 expression in the Ipi-Nivo arm. In an independent study using the same antibody, 28.8, for measurement of PD-L1, we can see that non-epithelioid mesotheliomas have a higher level of expression. So it is possible that this enrichment of PD-L1 in this group of patients could also be carrying with it an enrichment of non-epithelioid patients. And as we've seen, this could be a group that are drug resistant, accounting for this lower benefit from chemotherapy. And of note, in supporting that notion, is the fact that in this study, PD-L1 itself was not prognostic. So in terms of future directions and opportunities, chemoimmunotherapy has obviously changed the way in which we treat non-small cell lung cancer. This is now emerging as a modality under evaluation in mesothelioma. We have the DREAM and PRE 505 and 505 studies, which are looking at Nivolumab and pemetrexed. Both of these have been reported. And we now have phase 3 trials examining anti-PD-1 pembrolizumab with chemotherapy versus chemotherapy, and bevacizumab, atezolizumab, and pemetrexed versus the MAPS1 triplet to evaluate immunotherapy in a phase 3 context again. This is the ETOP study that's enrolling. I should say that there's another phase 3 trial which has completed accrual. This is the confirmed study, Nivolumab versus placebo, and we're using the 22C3 antibody for PD-L1 examination of that biomarker. Now, immunotherapy can be combined with chemotherapy when thinking about Ipi-Nivo. This is based on the recent 9LA design presented at ASCO, hazard ratio 0.66. And certainly in the case of the epithelioid mesothelioma, where we're seeing no significant difference between the chemotherapy and the Ipi-Nivo, one possibility is that chemotherapy could enhance the combination, be synergistic, in order to push up survival in that epithelioid subgroup even further. Can we target the non-epithelioid subgroup to augment immune checkpoint inhibition? Well, possibly yes. There is an enzyme, arginine-succinyl synthase, which is methylated in non-epithelioid mesotheliomas. This leads to a dependency on exogenous arginine, which can be deprived using an enzyme known as arginine deaminase. And this creates lethality in the lab. It also has a signal of activity present in patients. This is the ADAM study. It can be safely combined with chemotherapy. And in the ATOMIC trial, which is a randomized phase 2/3 study that's currently enrolling globally, if this study is positive, it would strongly suggest that arginine deaminase combined with chemotherapy may be a rational combination to think of with Ipilimumab and Nivolumab. So in summary, Checkmate 743 has shown a transformative improvement in patients with non-epithelioid mesothelioma and heralds a new standard of care in this setting. Non-epithelioid mesothelioma, the histology is associated with marked chemoresistance, and this is almost certainly associated with EMT, but is not positively predictive. And looking forward, chemoimmunotherapy involving all histologies or selective targeting of non-epithelioid mesothelioma could further extend benefit for patients with Ipi-Nivo. So with that, I'd like to thank the scientific committee for the opportunity to discuss Checkmate 743. And I'd like to thank you for your attention.
Thank you all for great